The treatment. I like to go directly now to the treatment. This is a very important point that cracks. I remember Dudley Glick gave me this slide 50 years ago. He said, Marwan, yeah, it's bacteria here. Absolutely bacteria. And we always believe bacteria in the crack. Actually, it's bacteria toxins. So we move all the way to 2015. And we have Rikuchi studies in which they actually histologically and bacteriologically found that cracks, it's full with toxins or bacteria and go right to the pulp and cause the problem. You can see now what we are talking about. Cracks are bacteria loaded. Restoration with lithium disilicate glass ceramic. And this is contribution from Dr. Francisca Vialti, one of the best additive dentistry from Switzerland. And I like to show you this. This is really a good conclusion for the first part. You're going to see colors. This is published by Dr. In 2002, Dr. Lynch from Canada. It's an excellent point. This summarized all my philosophy. The white was written, everything was white. What I've done, I discolored it in red. This is their chart. All I did is change the color and added few points. For example, I disagree with the concept of putting a band, an orthodontic band. We do not do that. I do adjustment only if necessary, selective grinding, not total reduction. You can see here now, this is if you don't have a pulp involvement. My treatment, if the pulp is vital, we do direct composite and then BLDG, building ceramic overlay. Here's another one. If you do have a central and you have a pulp involvement, it says here, put a band, remove the pulp, observe, don't finish the endo till everything's stabilized. I disagree. I considered cracked teeth emergency care. When you see a crack, go ahead, determine the proper diagnosis. Are you going to keep the pulp or are you going to remove the pulp? You're going to do endo or you're going to do direct composite and overlay ceramic glass. So if the pulp is involved, I do atraumatic endo, single cone endo, no post, composite bonded restoration overlay. If the endo is not involved, I do direct composite bonded and then the ceramic overlay. Now, if the tooth is hopeless, you have a fracture. Here it says, this is what they say, hopeless prognosis, you have this, pulp floor, you do this, all of that, you extract. No, no. If the tooth is hopeless and I have a lesion, I'm going to do something else. If it's a line crack, I do bonded and composite. If it is fracture, I do, if it's totally possible, I do exploratory surgery and I do interim surgical endo. And so let me go now to the diagnostic. One of the things I really propose, this is now like conclusions of my lectures concerning the cracks. I'm going to have to take 5 more minutes to expand. Is that okay, Eddie? We're going to expand a few more minutes?
Absolutely.
Okay. So the conclusions concerning the cracks, we need to listen to what Cameron said. Make it part of the dental school curriculum. So these are concepts, cracked teeth related diagnostics. Diagnostics mean a concept and a method. I really believe that general students, general practitioners, in-depth knowledge of the prevention, diagnosis, and management of cracked teeth should be an integral part of the dental school curriculum. We should teach cracked teeth like we teach composite restorations. crown preparations. In practice, it should be a test, part of the dental examination. I call it ROTC, rule out tooth crack, rule out tooth crack test. I believe that we should train our dental hygienists and coach them on how to educate patients when encountering a cracked tooth warning signs. They're doing scaling and root planing, and they see old restoration and a marginal crack. They shouldn't just continue their oral hygiene care, dental hygiene care. That's important, prevention. They should basically be able to educate the patients. And the dentist should train them how to do that. And they should talk about the 6 reasons why. This is why we should remove all restorations. If the margins are discolored, it's bacterial microleakage. Underneath that restoration, who knows what? There's hidden cracks. We should remove this restoration, disinfect with sodium hypochlorite, 5%. Sodium hypochlorite, 5%, kills bacteria in 30 seconds. So I disinfect the crack area and then place composite if the tooth is vital, and then replace it with good restorations. Here's examples. This is discoloration. You see, this is micro leakage. Micro leakage. The hygienist should bring this to the attention of the general practitioner, prepare the patient so the dentist will complete the treatment. It's so important, not only preventive, but also it's good in terms of productivity, good in patient service quality. All right, so we come now to the last part of the lecture. Endodontically teeth could be hopeless, restoratively hopeless. Perforation, broken instruments, fractures, hopeless. But the socket, the alveolar bone, is not hopeless. These are some pictures given to me by my friend, Dr. Odette Bahat. I put this down. Endodontic treatment of central incisor may not be easy after all. You know, in the dental profession, we believe molar is complicated. My PhD was in research in complexity of endomolar versus centrals. And everybody believed that centrals are easy. Do you know that my most surgical tooth is the lateral incisor after the first molar? Why? Because of mistakes. So central endo could become very complicated. And you can see it starts with a root canal and end up with this. Endodontic treatment on centrals may not be easy after all, especially if you are that patient. There are challenges, anatomic challenges. The thickness of the buccal bone is 1.5 to 2 millimeters. At the cervical zone, 0.5 millimeter. As you go up to the apex, 1.5 to 2 millimeters. On the lingual, you have 5, 6, 7 millimeters. So the lingual is not a problem. The palatal is not a problem. It's the buccal. You may also have a lesion. When you lay a flap, you see a lesion. You have the buccal undercut. Proximity of the nasopalatal canal, 4 millimeters. The floor of the nose, 10 millimeters. When you extract centrals in the darkly treated teeth, they could be very fragile, especially if the crown broke. So extraction could create with more problem, more defects, as you can see those pictures. And then you're going to do GTR, GPR, augmentation, et cetera, which everybody knows. They're not as simple. GPR, GTR are time consuming. They're very costly. The results are not predictable. You may have to do 1, 2, 3 surgeries. And aesthetically, you may still have a problem. The posterior teeth is different. Anterior is totally different animal. So these cases are hopeless. Critical size defects. All of these teeth are cracked. I treated them in San Marino. I treated them in my office here, etc. I want you to focus on this case. This is a 19 years old patient given to me by one of my colleagues here. And she had 4 or 5 years of orthodontics. And you see this lesion here, and you see no root resorption. That means possibly this bulb was necrotic before the ortho. They did a root canal on it. The lesion did not go. It developed fistula tract. This is 19 years old female. Well, apparently, when the lesions stayed, they decided to do the tooth next door and next door. I don't know why, but this is what happened. Then a periodontist decided this tooth is hopeless, and they did this. As if there is nothing called retreatment, as if there is nothing called apical surgery. This tooth needed exploratory surgery to see what it is. This is what happened. They extracted the tooth. And this is what happened. You could see now the defect has almost near the floor of the nose. And we have a huge defect now. And this is the way it is now. So this simple root canal treatment on the central was not simple at all. You see the complications. We heal. Endodontic treatment heals lesion before and after. 92 to 97 predictability. You take a lesion like this, and this is the result. And the beauty of this, while this is healing, the patient is using the tooth, functioning and aesthetically. In implants, you cannot do that. And that's the beauty of interim surgical endo. We're taking cases like this lesion and we could create this bone. No augmentation from here to there. Look at this bone. Native bone, patient bone, dense, most suitable for implant placement. I published this in 2010 in Journal of Oral Implantology. So my contribution is this. When you have an infected socket, you could extract, you could wait, you could do GPR, GTR. I propose we do this, interim surgical endo. This can be done by an endodontist, can be done by a periodontist, can be done by implant dentist, by maxillofacial surgeon, by trained general practitioner. It's a simple procedure. So what do? Basically, what we do is this. You lay a flap, which is not envelope, you just go a little bit higher, go up, expose the problem. What do you find? You find a crack, you find a perforation, you cut it, varnish the gutta percha, varnish it real good, and close. I started this in San Bernardino, California. 72 years old came to me, the tooth was going to be implanted. The patient developed emergency pain. The dentist in Pasadena sent me the patient. I tried to do root canal. I did. Look how what I went. This was calcified. I couldn't go deeper. So I did this. I went up and I did the curettage only. I did not put retro because there was no opening. Patient felt better, came back in about 8 months, and this is what I got. This is what started the interim endo. Patient went back and did the necessary treatment. Then this patient came to me from New York. Teeth were cracked. I removed the crowns, checked, made the new provisional, and then we went in and just basically removed the amalgam, did the curettage, and here it is in 6 months. This is a brand new bone. And then he went back to his prosthodontist. This is in Paddy. Here we did this. The patient had perforation here, palatal root. Basically, I didn't extract the tooth. I went and did hemisection. I removed the palatal root. This is the abscess, the damage in the palatal, the perforation and all this bone. This is now 8 months later. You see the beautiful bone. I kept the buccal roots. And then we made a provisional using the buccal roots only for 9 months. Here it is provisional. And then we placed implants in those buccal roots. You can see this is the mesiobuccal, this is the distobuccal, the palatal all heal, and then this is the implants. This is another case. You can see the sinus closed, overfilled. I did exploratory surgery. Here we have a crack, the flap. I removed this segment. This is what I kept. I kept only this, burnished this, and then you have a new bone, and then you restore it with the implant. So you don't have to go to the sinus, you don't have to expose it. So when you have a critical anatomy, you could do these things. Otherwise, you could do your standard approach for site preparation. So I call this endodontic site preparation, because you have Salama bring you the orthodontic site preparation. I am introducing the concept. Endo could be useful for you, and all of you can do a simple lay flap and do it. Why? Because most of the teeth we're doing in the anterior zone are endodontically treated and failing. So you could use that tooth for 8 months, 6 months, a year, get the patient bone with minimal augmentation or no augmentation. I do not use any augmentation. And then I have a healing, and then extraction become easier. You can see now extracting this tooth is so easily compared to, normal extraction. So interim surgical eliminate infection, preserve bone, physiologically, aesthetically, promote native bone healing, reduce the need for GBR and GTR, provide an opportunity to examine the status. When you lay a flap, you see the whole situation, and you know exactly as an implant dentist or a periodontist what you're going to do when you want to place a new implant. So it gives you exposure to the neighborhood, the neighboring teeth, quadrant dentistry, not a single tooth dentistry. Facilitate atraumatic extraction, prevent exposure of critical anatomical structures. I thank you so much for this invitation.